Professor of Diabetes and Endocrinology at Mansoura University, and I welcome you all in Egypt. Perhaps this is my first and might be my last time because I have only one lecture during this semester. I'm going to talk to you about Cushing syndrome. As you know from your previous studies, that the adrenals are divided into cortex and adrenal medulla. And the adrenal cortex is divided into 3 zones. Each one is responsible on certain hormone. So we have glucocorticoids, mineralocorticoids, and adrenocorticoids. And then the medulla had the catecholamines. My concern today about Cushing is the glucocorticoids, because for sure you are going to have other lectures on the other zona of the adrenal medulla. If it comes to the physiology of cortisol and its regulation between the suprarenal and the pituitary, as you know, we have normal circadian rhythm for the cortisol, which is at its highest peak early morning, and it becomes very low during the evening. And it's nearly 1/5 its amount in the early morning. And this is why, while giving corticosteroid or withdrawing corticosteroid written, prescribed by the others to your patients, you have to respect the circadian. If you prescribe one dosage, that should be morning. If you prescribe more, then majority of the dosage should be morning, and night dosage should be less. And if you withdraw a drug, then you have to withdraw the night dosage first, and keep the morning, and then decrease it, and so on. So in every hormone, we should respect its circadian rhythm. The same like, for example, replacement of growth hormone, which we all know that its peak is by night while your patient is sleeping. So then you have to encourage the child with growth hormone deficiency to sleep early, not to sleep at 6 as they do in summer or by 7 o'clock in the morning, because by that time, if your injected exogenous dose of growth hormone doesn't find your child sleeping around 2 p.m. to a.m., then the growth hormone is not going to function. Any abnormality in this circadian, whether induced by physician or sometimes induced by traveling. If you travel from here, for example, early morning, and after 12 hours of traveling and transit and so on, then you find yourself in another country that for you yourself, your hormone should be now down as you are having the second half of the day. And if you come to a country where you have now morning, then you are going to have what's called jet lag. And this is one of our major hormone responsible on that jet lag. Accommodation to that jet lag for the second day and third day, then you have the circadian rhythm of the country of your destination. And then it happens again on being back to your country. One of the stressful situations, you know well that like all other hormone, we have the maestro of the endocrine gland in the hypothalamus, which releases corticotrophin releasing hormone. From here, secrete the adrenocorticotrophic hormone, which is called ACTH, which affect the adrenal, leading to cortisol. Cortisol have a special, like all other hormones, they have feedback both on the corticotrophin releasing hormone and also on the ACTH. So if you have excess cortisol, automatically you are going to have decreased amount of corticotropin releasing hormone and decreased amount of ACTH. The physiological situation that increase cortisol by this normal mechanism is mainly stressful situation, any stressful situation. From being good stress, like physical exercise, and this is one of the reasons why individuals after exercise, they feel good, they feel in good mood. Although tired of having exercise, but they have raised the mood. This is one of the reasons because of the released hormone next to this exercise. Emotional stresses also might lead to cortisol. Emotional, whether sad or happy. Then you have more cortisol in your blood, and the reaction depends on the catecholamines then, whether you're going to have tachycardia of being happy or tachycardia of being sad. The hypoglycemia also, the cold exposure release more cortisol, and the pain. And this is why it's not nice to, for example, consider diagnosis of a patient with hypertension while he is in severe pain. Then you have to revise him after that, because this is a condition of hypercortisolemia that might lead to mild increase in blood pressure. So you should know a little bit about the physiology, then you can apply it for your patient. And this is in health, and then we are going to discuss in disease. The adrenal cortex hyperfunction, which is one of them is our topic today. I'm going to talk about Cushing. The increased aldosterone is called hyperaldosteronism. I think it's going to be told to you by Professor Umayma Saleh, and the virilization syndrome, where the testosterone is increased extraordinarily in a female patients. The Cushing syndrome is based on this biochemical that you for sure have in your biochemistry study. What cortisol do for our patients? They increase hypertension, they increase the incidence of diabetes, they cause certain type of obesity, with truncal obesity, moon fascias, and a buffalo hump at the end of the neck, and with certain cutaneous stria. I brought you some photos to show the difference between cutaneous stria of Cushing and that stria of obesity, and osteoporosis by the end if you leave your corticosteroid working in the patients. So the clinical presentation is we are going to have weight gain with truncal obesity and moon fascias, buffalo hump, and meanwhile, which is something very nice, you have to differentiate between it and obesity, because obese individuals have what's called pseudo-Cushing. In pseudo-Cushing, there is obesity, it's more truncal, it might lead to moon fascias if your patient is morbid obesity, but here there is muscle atrophy, and muscle atrophy more proximal is due to corticosteroids. So if you find your patients obese, mainly in the trunk, with lean limbs, this is very characteristic that this is not normal obesity. Hypertension, diabetes, fragile skin. Let us have it on a photo later. And I think that this way of studying for you is very nice. If you have your patient with the signs put on it, then you are never going to forget any of the signs. Because we have a quotation in medicine, if you don't know the sign you are searching for, you are never going to see it. So if you don't know the sign, you have it from your atlas, you have it in your mind, you have it in your knowledge, you are going to pass it when you see it by your patient, because you don't know that this is something significant. So we have to be careful to look after all signs, even those rare conditions that we are never going to see, or we don't know when we are going to see. But you should know that there is something called so and so, and if I see it, then I could be back once to my book to see what syndrome was having this sign. But you, as physician, should know a lot about any physical sign that's even extremely rare to be found. So if you look at your patient, and this is the way we examine our patient from up down, for example, or from down up, as you like, you find here thinning of the scalp hair, like those happening with drugs or with hypothyroidism. The acne is very common, and it could be not at the age where acne is normal at your age, but this is acne at 40 years individual or at very childish age. So this is acne in an abnormal age for acne, and it's usually very aggressive with moon face, the buffalo hump. And we are going to have the patient from the lateral view now to show you the buffalo hump. There is hyperpigmentation, and this is very important. The hyperpigmentation is due to increased ACTH secretion. And this is usually, as clinical, is the only clinical sign that differentiates you between suprarenal Cushing and pituitary or hypothalamic Cushing. It differentiates you clinically. If you have hyperpigmentation, you can say that this patient is pituitary, because only the ACTH has melanocyte stimulating hormone activity, and it induces hyperpigmentation. It's not only this. If you have a scar of well-known duration for the patient of previous operation, and it is hyperpigmented, so you can also document the duration of having Cushing in this patient. So the hyperpigmentation should not be overlooked. This is one of the signs that should be mentioned even in negative. If you see a case of Cushing and you are describing the case, you should mention there's no hyperpigmentation. That doesn't mean you exclude being ACTH, but does mean that I'm in favor now during that clinical examination that this is a case of suprarenal Cushing. Its absence is not as significant as its presence, but this is one of the important signs that should be mentioned both in positive when it is present and in negative, pointing to the possibility of being suprarenal Cushing. Truncal obesity, we have mentioned. Thinning of the extremities. This is very characteristic if you see a case of Cushing, and I'm sure you are going to see during your clinical round. Thin extremity is something very, very, very characteristic for Cushing. And the skin, because of the thinning next to corticosteroid, is usually easily bruising. So you can see thinning, that you can see the veins across the skin, and you can see easily ecchymosis here and there, even in areas which is not in contact with any trauma. I mean, you can find ecchymosis, for example, in the middle of the thigh, at any part that's not exposed to trauma. It can happen spontaneously. Meanwhile, you can have facial hair, and I'm going to talk about the hair. The supraclavicular fat of fat pad, the stria, is typically here present in an abnormal size. You can find, for example, stria of pregnancy around the anterior abdominal wall because of the rapid stretch of the anterior abdominal wall, especially if they are, if the lady is pregnant in twins. So you see a lot of stria. The stria here is different. It can happen in any place. It could happen on the breast, in the axilla, in the thigh. So this is not a normal site for having stria of obesity or of pregnancy. Plus the pendiculous abdomen, but this can have pendulous abdomen could also happen in morbid obesity, especially when the patient loses some weight. So from the lateral view, this is a buffalo hump, this is a moon face, and this is a typical purple stripe. This is from lateral view if you want to revise it. If your patient has wound, then if he is Cushing, he is going to have slow wound healing, delayed wound healing. The same as steroid-induced immunocompromised patients. So he is going to have severe infections, mainly fungal infections, and if they have wound, they are going to have delayed wound healing. There is some psychological also manifestation for increased corticosteroid, and it also happened with the removal, with the withdrawal of corticosteroid from your patient. The patient with hypercortisolemia at the start, he might have euphoria. He's like, big wow, I'm having more power, although he's having less muscle power and he's losing his body. But it induces euphoria, and though sometimes it causes depression, and it causes sometimes emotional lability. Take what you want from this photo, but you have to remember all the signs. And this is a stripe. This is very typical place where obesity don't, pregnancy don't, but a patient with increased cortisol, they usually have this side of Cushing, of stripe. This is also very specific. If you see a patient with, for example, pregnancy-induced stria or obesity, rapidly increasing body weight, you are going to have the stria very thin and not such color. The characteristics of the stria of Cushing is that it is white, but you can put your finger. It can be a finger width, which could never happen in obesity. In that, it's usually depressed because of the thinning of the skin, which doesn't happen also in obesity, and it's usually purple, active, not like that of obesity or pregnancy. This is also an abnormal site of hair distribution in female. If you have a female in your clinic complaining of excess hair in normal sites, what we call non-hormonal dependent sites, which is the arms, the legs, this is quite normal. The pubic hair is also, but it has some hormonal dependency in the attitude. For example, the masculine pubic hair distribution is towards the umbilicus. The feminine pubic hair distribution is transverse. But these sites are extremely hormonal dependent. If you found in a female hair on the back, on the chest wall, on the anterior abdomen, or the inner aspect of the thigh, heavily, because in the late manifestation of puberty, one of the latest in the hair cycles of growth is the hair growth at the inner aspect of the thigh, but it should be directly at the inner aspect of the thigh, not that extended into the thigh. So this is the characteristic hair suits that's present with Cushing. This is the most important slide in my presentation, I think, because this gives you a resume on the differential diagnosis of Cushing when you see a patient with increased corticosteroid. You have to think of what we have as suprarenal Cushing or pituitary Cushing. This is with high ACTH, this is with normal ACTH and excess cortisol. But we have two different other types of Cushing, and actually they are not rare, they are very frequent. The iatrogenic Cushing, where you should extensively have history taken from your patient that he is having injection or oral or even local corticosteroid for longer duration. It's written that even local corticosteroid might induce Cushing. And the paraneoplastic Cushing, where there is ectopic ACTH secretion from the mainly bronchogenic carcinoma. So if you have a case of Cushing and you are faced with it, while taking the history, you have to have these four items in front of you while taking history and doing examination. So you have to ask your patient about any drugs or so and so to exclude this. And then you have to have a lot to exclude chest, and even X-ray chest should be routinely done for a patient with Cushing to exclude the paraneoplastic. Then you can exhaust yourself with a lot of investigation, and the most important sign we said about hyperpigmentation to differentiate between adrenal Cushing and pituitary Cushing. The first phase reaction in presentation of Cushing patients is the loss of circadian variation. This is the normal we have mentioned, that your patient early morning has low corticosteroid that rises. This is by night, I'm sorry. Here, early morning, around 8, you have your peak. This is the maximum activity of most of us. And then it decreases gradually until 12 o'clock or 10 to 12 o'clock in the evening. And then it starts its rise again to 8. The first sign of having a patient with hypercortisolism is the lack of circadian rhythm. For example, here, if you have a patient with 25 plasma cortisol level, milligram per deciliter, then your night dose is going to be around 5. But in a patient with increased corticosteroid, there is loss of circadian variation. You are going to find the morning 25 and the evening 24, for example, or 23. So the lack of circadian rhythm of cortisol level in the blood is our first sign of diagnosing Cushing. For laboratory diagnosis, and as you know, most of the levels of hormone, they are under continuous hemodynamic level of up and down. And this is why when we have to take a sample for any hormone, we have to leave the cannula for the patients, and in different minutes, according to each test, in different minutes you can collect more than one sample. Some laboratory advise to collect these samples together and work it as one sample for the cost of the kits. In other laboratories, they do the different samples they got from the patient and they take the average of the measures they have. So it depends on your target, but it should be usually more than hormone, because you know the circle of up and down of each hormone around its basal level. One of the alternatives for that is to collect the 24-hour urinary cortisol. If you collect 24-hour urinary cortisol, this gives you an impression of the whole reserve of cortisol secretion in the blood. The loss of diurnal variation we have mentioned, and we have a test called dexamethasone suppression test. Actually, there are two. A low dose dexamethasone suppression test. I don't know if it is, if you have to have all details or no, but I'm going to give you brief, and if you found that it is your responsibility to know details so you can pass through. The low-dose dexamethasone suppression test, if you have a patient with possible hypercortisolemia, and you give him dexamethasone as low dose in the night before, and then you take your cortisol early in the morning and then in the evening, what are you expecting if your patient have hypercortisolemia? If not, if he doesn't have any cortisol hypersecretion in his body, it's going to be suppressed. I mean, if he's already taking his night dose that's going to have its peak early in the morning, so the patient cortisol is going to be suppressed. And this is why the low dose differentiate between true hypercortisolemia or not. If you have suspicious level and suspicious level of plasma cortisol, then the short dexamethasone can tell you this is hypercortisolemia, this is not hypercortisolemia. The high dose dexamethasone, where you give your patient dexamethasone for 3 days, and then you retest your patient. This differentiates between the pituitary hypercortisolism and the adrenal hypercortisolism. If the adrenal hypercortisolism is still working, and the axis of ACTH is working with it, if you increase the dexamethasone for 3 days, you are going to find suppressed ACTH, because the main here is the suprarenal hypercortisolemia. But if you lost that axis, if the ACTH is high, it wouldn't care if you increase more dexamethasone for 3 days before. You are going to find the same picture. So low-dose dexamethasone differentiate between hypercortisolemia and not, and high-dose dexamethasone suppression test differentiate between being suprarenal and being pituitary. Our patients usually have diabetes and hypertension. This is very important because you have to care, and the full trip until your diagnosis of the patient, which type of hypercortisolemia he has, is sometimes prolonged, especially in the developing countries, where you have to wait for MRI, and you have to wait for, and so on, you have to wait for CT, and you have to wait for the cortisol level, and so on. This would be long time enough. And usually our patients die from cardiovascular manifestation of being hypertensive, or from its diabetes complication, or from infection, because they could have serious infection that end their life. So one of the important issues in the clinical picture is to care about the hyperglycemia and the blood pressure, even if you are GP or whatever the branch of medicine you have met, the Cushing first. Then you have to care about being hypertensive, about being diabetic, about his infection. This is more important than the endocrinologist who is going to care about which level he is going to intervene and which level he is going to diagnose his patient. This is most important for the life of our patients. And this is why it's mentioned in the laboratory that you should care about diabetes and increased sodium and decreased potassium. That leads to sodium retention that might add to hypertension. For radiological diagnosis, we all agree that routine chest X-ray should be done. And I remember since, and I have used to tell this story for all students since that time, that we have had a neurosurgeon since, I think, 8-7 years, who has diagnosed wrongly the ACTH is high, and he has done pituitary hypophysectomy for a male individual aged 40-something years old. And after that, he has consulted an internist because the patient post-operative chest condition is not okay. But he was sure of his diagnosis that the ACTH is high repeatedly, and he has some pituitary tumor, so he has removed the pituitary. Our colleague, when he went there, he has asked for an X-ray chest, and he has found that the source of ACTH secretion was bronchogenic carcinoma. So the patient has passed unnecessary hypophysectomy because any one of us has not passed through the regular schematic way of investigating a case of Cushing. We have different data about pituitary hyperplasia next to ACTH secretion, even if it is ectopic secretion. You know that the pituitary hyperplasia can occur next to any abnormalities in the feedback mechanism. So it doesn't mean that you find pituitary tumor that this should be removed. You have to well assess your patients before passing into such operation in an already critically ill patient with tumors. So chest X-ray should never be forgotten from your mind if you see a patient with Cushing. The pituitary imaging, the best pituitary imaging is MRI with contrast. And I feel sad actually when we in the examination found that students always assess anything in the skull as skull X-ray, CT, MRI. I feel that the students are mentioning all what they know. But look at yourself if you are working, especially in developing countries, where this is very costly and you have to arrange for it for 4 to 6 weeks. And the other one is very costly and you have to arrange for it. So look what you are doing. It's not a matter of filling the space in the paper, because this usually leaves, at least on me, a very bad impression on the student that he's just mentioning all what he knows. You have to be careful that looking for the pituitary, it should be an MRI with contrast. This is the best imaging procedure for the pituitary. No radiologist anywhere in the world are going to refer for him pituitary CT, and he's not going to do it. He's going to do it, and at final of his report, he's going to recommend MRI with contrast, as this is a pituitary and I can't see it well, and. So no one is going to tell you, unless he is one of your friends or so, he might give you a phone that it's better if you're looking for pituitary to have an MRI pituitary with contrast from the start, not to have MRI and then he's going to recommend for you another MRI with contrast and so on. So please be careful. When it comes to the pituitary, whatever the disease you are looking for, when it comes to the pituitary, we have to do, or we have to ask for MRI pituitary. Because having CT, MRI, and so on doesn't happen at any place. Even those who have this and this, they have to justify why you are asking for both. If you are faced now with a case of adrenal, then you have to recommend a CT on the suprarenal. And this is very important to be mentioned in your request. Not to say CT abdomen. Because if you are asking a radiologist to do CT abdomen, you might have a cut, for example, to give you an impression on the diaphragm and stomach and so on, liver and gallbladder, and the cuts are wide. If you don't mention for him, what are you looking for? So he's not going to have a patient with different cuts. He's not going to have his patient 2 hours, for example, on the table to have you, to screen for you the abdomen. So if you are searching for hepatoma, you should tell him this is possible hepatoma. If you are searching for the suprarenal, you should tell him CT suprarenal, because then he's going to have white cuts in the upper part of the abdomen, and when it comes to the renal and suprarenal, he's going to have more frequent cuts for CT suprarenal. So you have to request it as CT suprarenal, not CT abdomen. The management, and this is my last slide. In very short, the general measures is what we have told you about. We have to care about the diabetes state, the infections, the drugs to be withdrawn gradually, and we have now in our clinic a case of Cushing following one single depot injection of corticosteroid. It could happen with very small doses that you are not waiting for Cushing to happen from it. So you don't have to underestimate the effect of corticosteroid taken by the patient, or to underestimate the way we have to withdraw. And I'm sure that our colleague who is going to talk to you about Addison disease is going to insist on how we withdraw corticosteroid. Doesn't mean that you see your patient with Cushingoid fascias next to corticosteroid, that you remove all corticosteroid, because you don't know now if this is a manifestation of previous Cushing and your patient is now passing into suprarenal failure, or this is an active Cushing. You have to follow the guidelines of withdrawal of corticosteroid and respect that, whatever small the dose he has. Among the general measures also is to control diabetes, even if especially if the patient is going to pass operation, then you have to strictly control his diabetic state. You have to care about infections, everything in the general measures, and this is not less important than what the endocrinology are going to do, because the patient is lost due to these diseases. The specific treatment, as any endocrinal disorders, is surgical. If you put your hand on suprarenal, or if you put your hand on a pituitary tumor, or bronchogenic carcinoma, if he is operable, then you have to get rid of the tumor. But this is actually sometimes very difficult. Sometimes you are faced, even in the best center all over the world, you are faced with a case of hypercortisolemia, and you failed during the work because of the dilemma of the feedback we have between cortisol and ACTH and the different timing we have our samples and so on. It's very difficult sometimes to differentiate whether it is suprarenal or pituitary. And this is why in some specialized center there is some interventional radiologists who do something like petrosal sinus sampling, that you go with something like angio case until the petrosal sign, and then you take a preferential sample between the right lobe of the pituitary and the left lobe, and if they differ, so there should be here a pituitary secreting ACTH. So it's sometimes difficult that you don't find the tumor, but you find increased ACTH. Here, because we don't have this, we do care about the general measures and wait to reassess our patient after 3 to 6 months if you don't have such an intervention. Then usually after 3 to 6 months the picture is blown, whether it is pituitary or suprarenal. The medical treatment during that time for the adrenalectomy is very important as well. One of the drugs that was used as medical adrenalectomy, if the reason is suprarenal, but without having a tumor to be surgically removed. I mean, there's only hyperplasia, hyperactivity, hypersecretion, but there is no tumor to be removed, and you don't know whether you have to remove the right side or the left side, but you know that there is excess cortisol from this suprarenal, or one of these. Then we have what's called the medical adrenalectomy. Before that, we have one of the antifungal called ketoconazole. It's used as antifungal for the skin dermatology problems, and for us as endocrine, it is used as medical adrenalectomy because in its large dose, it intervenes with the enzymatic process of forming cortisol and stop the formation of the end product. So whatever the stimulation is coming from the ACTH, or it is autonomous secretion of the suprarenal, the end product of having cortisol is blocked. And this drug was very successful, and you have even to care about it with the incidence of Addison, which is hypoadrenalism, because that drug, if you block all cortisol, it can induce hypoadrenalism. But for some toxic side effects this drug has caused, it was withdrawn from the market. Other two drugs are now available for medical adrenalectomy, like metirapone, and one new just approved from the FDA last month. They are not present in our market, and I don't know if you are interested, you can have more details. The irradiation, of course, only of the pituitary. We don't have irradiation for the suprarenal, but if it is pituitary, and especially if it is not invading the other structure, and your patient refuses to do the surgery, which is real radical modality, or if the patient for any, the physician surgeon, for any trouble during the operation, he has removed the minor part of the pituitary and come out with the rest residual pituitary tumor, you can give your patient irradiation on the pituitary. The traditional radiation that's present in the chemotherapy department and the oncology department is sometimes used, but with a side effect that the range of radiation given for the pituitary couldn't be strictly controlled to the pituitary tumor. So usually, this radiation to the pituitary ends in hypopituitarism, pan-hypopituitarism. And this is going to have, this is why you are going to have radiation as one of the main causes of pan-hypopituitarism. If you do it for yourself, for your patients, that does mean iatrogenic. Recently, we have another form of irradiation called the gamma knife, which is condensed laser beam of therapy that can affect the, it's done under screening, so you are seeing the pituitary while you are working, and the gamma knife can directly affect the pituitary tumor, saving the rest of the pituitary. The disadvantages of this is that it's not available everywhere, but thanks God we have 2 centers now in Egypt having this gamma knife technique. So it's not present everywhere, you might not find it in a complete government or so. And the second is that this tumor treatment type usually rapidly produce cessation of hormonal secretion. But the decrease of the size of the tumor, it usually takes a long time. So if your patient is mainly complaining of increased intracranial tension signs, like his visual field is affected, he has diplopia because of papilledema, if he has headache, if he has projectile vomit, I mean, if the mass is getting out of the pituitary, the gamma knife wouldn't be your best management because it's going to stop cortisol secretion, or ACTH secretion, I'm sorry, but it's never going to halt the size of the tumor rapidly. So it is a good choice if the pituitary tumor is still in the sella turcica, and that your patient doesn't have increased intracranial tension. Otherwise, you should shift to surgery and insist on your patient that surgery of the pituitary or of the suprarenal, according to the cause, is the best choice you have. Thank you so much for that. This is a photo of twin, to end. You look, if your patient is having Cushing, she has moon facies, she's in a quite different size, and she's also stunted growth. And any excess cortisol at childhood, whether iatrogenic or exogenous, is going to cause short stature. Thank you. Assalamu alaikum.
Lepas saya cedera kak.